Greetings, everyone. Good morning, good afternoon, good evening, depending on the time zone from which you are joining us today. On behalf of the Eastern Mediterranean Public Health Network, Infinite, I would like to warmly welcome you to today's webinar titled The Role of Immunization-Focused FETP in Preventing and Controlling Vaccine-Preventable Diseases in Fragile Settings. I'm Dr. Amna Khairi, field epidemiologist and a technical specialist at the Center of Excellence for Applied Epidemiology at Infinite, and I will be moderating today's webinar. This is very important topic and obviously of interest to many, as we have more than 600 actually registered participants for this webinar today from the AMR and beyond. We are pleased to have colleagues joining us today from Ministry of Health and WHO, different FETP programs, immunization programs, surveillance department, emergency preparedness teams, partner organizations. As it's well known, field epidemiology training programs are long-established competency-based workforce development programs that have played critical role in strengthening global public health capacity for several decades. Now we have hundreds of programs globally that have contributed to skilled field epidemiologists that are capable of supporting surveillance, outbreak investigations, general emergency response, and contributing to evidence-informed public health actions across different contexts. Over time, these programs have continued to evolve to address emerging public health priorities and operational challenges. This evolution contributed to the development of a specialized frontline training models tailored to specific technical operational needs. For example, One Health, environmental health, climate change, and among those are immunization-focused FETP programs, and specifically the frontline tiers, which is also named Public Health Empowerment Program. In many countries, and as in the region, continue to face fragile and emergency context, vaccine-preventable disease remain a major public health concern. These immunization-focused FETP programs have been particularly implemented in such context. In our today's webinar, we aim to highlight how these immunization-focused public health empowerment programs have contributed to strengthening frontline workforce capacities, supporting both surveillance, outbreak investigation, and these technical areas, and also operational public health functions in fragile settings. So before we start, I would like to note that this webinar is recorded, and we highly encourage all participants to actively engage throughout the webinar by posting questions at the Q&A section. And at the end, we will have dedicated Q&A session for responding to as many as questions and also your contributions and comments, of course, from our distinguished speakers. We truly look forward to an interactive and rich discussion today. And starting by our first speaker, I'd like to welcome Dr. Al-Tayyib Al-Faqih. He is a senior public health expert and epidemiologist with more than 25 years of experience in immunization, communicable disease surveillance, and emergency response, particularly in conflict-affected settings. He currently serves as medical officer at the World Health Organization, the regional office for the Eastern Mediterranean Public Health, the Eastern Mediterranean region. And before that, he served as or held several senior leadership positions, particularly in Sudan. Dr. Al-Tayyib, we really pleased to have you today, and the floor is yours.
Okay, thank you very much, and good evening, all of you, and thank you for Infinite. Thank you, Dr. Amna, and the organizers for inviting us for this important and very interesting webinar. And I am very pleased and honored to participate in this webinar and trying to discuss some issues related to this important topic from the perspective of our team. I am part of the team in WHO working on polio and vaccine-preventable disease outbreak preparedness and response. I'm also like representing vaccine pillar in different IMSTs and emergencies in the region. If you allow me, I will share my screen. Just a minute. Can you see my screen? Can you see my screen in response?
And not yet, Dr. Taib.
Sorry.
Beats and away.
Problem. I've done it now.
Maybe if you'd like us to share from our side, Ammar can support you.
Okay, please. Bye. Okay, thank you very much, Ammar, and sorry for this technical issues. Okay, great.
It's okay.
So, actually, this presentation, discussing some few points related to the evolving of the role of immunization-focused FETP program in fragile, conflict, and vulnerable settings in EMRA. Next slide. And first of all, we would like to just introduce you to the context of our fragile, conflict, and vulnerable settings. We have so many countries, actually, more than almost 12 countries out of the 22 countries in EMRO are in a humanitarian crisis. And EMRO now is like hosting some of the world's most complex humanitarian and protracted emergencies and crises in different countries. Fragile and conflict and displacement and health system disruption actually continues to drive vaccine-preventable disease risk in all those countries, and not only in the countries, and even it's crossing the border to other neighboring countries, as well as like having some risk for regional spread as well as for global spread for some of those diseases. Simultaneous outbreak increasingly occur under condition of insecurity, as you know, and limited access, as well as huge population movement. You see the situation in Sudan and in other countries. We have a huge population movement, and this actually affects the epidemiology of those diseases, not only vaccine-preventable diseases, but all other communicable diseases in the region. Routine immunization disruption has actually amplified during emergency, and we have seen that their dose has been increased significantly in most of those countries. Not only the zero dose, also the under-immunized children, which are the children who are not able to complete their vaccination schedule. And this is like a significant dropout for vaccination and setback for the vaccination programs in the most of those countries. Outbreaks, actually, we are like trying to discuss different outbreak and emergency cycles, talking about preparedness as well as talking about prevention, response, recovery, and resilience, and also like to make sure that we are discussing some issues related to strategic shifts that we aim to introduce and invent in the region in order to tackle issues related to emergencies as well as outbreak prevention and preparedness and response. Next slide. Sorry. So why this discussion matters now? Yes, I think it is now high time to discuss those issues. Now, actually, the epidemiology training in general has changed significantly. People now are talking about like the emergency intelligence in context of emergency. And we need to make sure that population mobility and cross-border transmission has been well tackled during those outbreak response activities. Also, traditional vertical disease specific trainings and approaches are becoming insufficient to deal with different emergency and as well dealing with different vaccine preventable disease outbreaks that happens not only because of emergency situation but also because of the increasing number of zero dose and susceptibility in the region. Emergency operations increasingly require integrated approaches. Now, as we can see from the experience that we had in the region, we have fragmented actually response. And in most of the cases, there were no integration in response activities conducted in different public health programs. Okay. And we need to think for having an agile frontline workforce, which should be capable and having the enough competencies in order to operate across different emergency cycles. Next. Changing the nature of emergency, as I mentioned, we need to look strategically to shift our mindset in order to support the response activities and to have simultaneous outbreaks and humanitarian crises being under control, and to have an integrated response activities, not only working in isolation, but also like working within the systems that we agreed for emergency. In our region, we have agreed on the incident management system, which include all sectors and which include also all and which accommodate actually the coordination platform for all stakeholders in order to share ideas and to also provide support for the countries. We need support from international community, and this is very important if we would like to shift to integrated approach for detection and response to vaccine preventable diseases in the region. Urban emergencies and displacements have significantly increased in most of the countries. And we have noticed this displacement happened in Sudan and other countries. And usually we lose some significant control upon the target population, denominator estimates, and also on the network that already exists and sometimes disrupted during emergency. And we need to make sure, we have flexible and adaptable mechanism for service delivery platforms or service delivery network in order to provide essential and critical primary health care activities during emergency. So our aim during emergency is to provide or to continue providing the critical and essential services, including immunization services. And the other critical role is to timely detect vaccine preventable diseases and effectively respond to those outbreaks in different settings. So those are our primary and critical role during the humanitarian emergency. And one of the issues also during humanitarian emergency, we would like to make sure that vaccination was on the top on the agenda and priorities in different countries. We noticed also that climate-sensitive outbreaks and environment risk has increased significantly in the region. attacks on health system and attacks on also workforce has actually increased in most of the war-affected areas. Operational also fragmentation and weak sub-national capacities have been observed. In most of the countries, we are like observing that the district level and the sub-national systems are weak and lacking some of the competencies which are very critical and needed in order to deal with outbreaks and emergency response activities. Next. Okay, FETP. We have huge actually mass of FETP trainees in most of our countries. If I recall well, in I think 17 countries in the region, they have like different categories and trainees in field epidemiology. We have also rapid response teams being trained in most of those countries and also deployed at all actually districts in also 15 or 16 countries in the region. And we think we need to shift the focus now. Instead of having this disease-specific training or just traditional epidemiology training, let us work to have like operational public health emergency platform. And this needs to shift also from passive surveillance support to outbreak intelligence generation as well. Also for our approaches as well as for our training to shift from disease-specific into integrated all-hazard approach or response. And also from short-term outbreak support to resilient building workforce model and also close the link with the EUC, IMST, and emergency coordination structure. And those shifts are strategically needed if you would like to have effective response to emergency as well as outbreaks. We have observed, let us talk frankly, we have observed in the field that in some areas, in some countries, those teams are usually not even talking to each other. And although we have this critical mass of field epidemiology trainees, we have also observed we are not using them to the maximum potential that we are intended to. People at countries and ministries of health and also at subnational levels, they complain of shortage of human resource. They are also complaining of unqualified health workers, lacking most of the competencies needed to timely detect and timely respond to outbreaks. Although we have a critical mass of field epidemiology trainees as well as rapid response teams in the field. So we need to make sure they are well involved in all cycles or stages of emergency and outbreak preparedness, prevention, and response. Next. When we are talking about management cycle for outbreak, we are talking about prevention stage where we have a lot of activities to implement in order to make sure we are preventing our susceptible populations from those outbreaks. We are also talking about preparedness, which involve also a package of activities that need to be conducted in order to make sure that we are prepared for those outbreaks in case they're happening. Also, we talk about early detection. And in our immunization agenda 2030, we have two critical indicators. We have indicator regarding early detection of vaccine-preventable diseases, And we have another indicator talking about timely and effective response for those outbreaks. And unfortunately, when we score those indicators in most of our countries, we are like far away from the standards that we need in order to protect our communities. We need to conduct a lot of rapid risk assessment in those settings, and we also lack capacities in countries. We need to also making sure we have an effective response, and we like to make sure we have an integrated response. And this is also lacking most of the competencies needed. And for recovery also, we need to have some package of activities, and still we need to look of establishing resilient communities in order to make sure that we guard our population or susceptible population or vulnerable population in those emergency settings from contracting those vaccine-preventable diseases. FETP can play a role in that and should contribute across all levels or all stages of emergency as well as for outbreak. Next. For prevention phase, and this is one of the important phases that we would like to work with countries, and we need to identify the immunity gaps and to make sure we are able to identify the zero dose and communities and population, and to restore those zero dose and to make sure they have been vaccinated and protected against those diseases. We need, as I mentioned, to have like a risk profile for all the population, for all geographical areas, for all vulnerable and hard to reach population. This is one of the things that we need to conduct during the prevention phase. Monitoring vaccination as well as monitoring surveillance and monitoring any inequities that exist in several countries because of emergency, yeah, and because of other maybe cultural, social, or political issues. So we have to look at that and to have like our a platform in order to deal with any disruption that might happen to the health system because of the emergency. Surveillance, as I mentioned, we have a lot of surveillance gaps in most of the countries. So we are conducting a lot of surveillance reviews, and we need support in those areas as well. Micro planning and the use of technology and GIS supported, especially for settlements mapping, is very important. Community engagement and risk communication support is also highly needed in most of those communities. Data triangulation for anticipating action is needed as well. So those are critical areas in prevention, and those can be provided to all countries, not only to the high-risk countries. Next slide. When it comes to preparedness, the most important thing in preparedness is to do the simulation exercises. We have a lot of outbreak preparedness and response plans, but we are not testing those plans in most of the countries. So we need to join hands in order to implement those simulation exercises during the preparedness phase. We need to support the pre-positioning of supplies. We need to have contingency plan and emergency as preparedness plan adapted, and should be a flexible plan that can be accommodating any developments in those emergency settings. We need also to make sure that we have like monitoring and evaluation framework and indicators to test the readiness in those countries. Also, rapid response team should be strengthened, trained, and qualified to deal with those different types of emergencies. And we have noticed in most of the trainings for rapid response teams are disease specific. So we are now talking about all hazard approach, all hazard training. So to prepare them to deal with different kinds of outbreaks. Uh, Also issues related to vaccination in emergency planning. The issues is still like lagging behind in most of those countries. We need to discuss how we can improve the knowledge about the vaccination in emergency, and also like also having a very critical mass of public health volunteers as well as public health officers who can work during emergency in order to maintain the essential services, including vaccination. We need to support the incident management system readiness and implementation of SOPs as well. And also resource mapping and shared capacity planning is very critically needed in most of those countries during the preparedness phase. Next. For early detection, the most critical area without going through all those points, like in the most critical area actually is the area of field investigation and for also event-based surveillance and signal verification. Most of those countries lacking competencies related to active case search and contact tracing and cluster investigation. So those are highly needed and they are very critical activities if you would like to understand the epidemiology of the outbreaks and if you would like to prepare or plan for effective response. So those issues related to field investigation, all components of field investigation is very critical, and we actually lack a lot of competencies in most of those countries. Also, we need to shift from passive reporting towards outbreak intelligence platform as well. Next. As I talked in the beginning, also rapid risk assessment is also one of the issue and challenges that we are facing when we are trying to plan for effective response. So we need the support of all those qualified epidemiology trainees to participate in this activity and to make sure that we have enough information about the risk to those population which are vulnerable, and to identify the immunity gaps that exist in different areas and across different population settings. Also, the health system functionality and the service delivery during emergency. We need to assess the situation as clear as possible in order to have like our backup, to have our also support to the health system in order to restore those functions as early as possible. Laboratory and surveillance gaps and capacities need support during emergency. Also, issues related to continuous dynamic reassessment during emergency is needed. Next. Outbreaks, as I mentioned, outbreak investigation, field deployment, search capacity to countries, issues related to data, line list management, and outbreak data analysis, especially when it comes to analytical analysis, monitoring timeliness, indicators of response, rapid vaccination coverage surveys conducted in order to assess the vaccination coverage and immunity gaps, monitoring outbreak response immunization and SIS qualities, daily situation report and operational dashboard, supporting the incident management system during outbreak also is very critical activities. Next. So one issue also, without going too much detail, is the lack of timeliness and accountability framework. So in most of instances, we are working without a clear accountability framework, and this is very much needed. Timeliness, as I mentioned, is like lacking in most of the case. And we couldn't manage to identify timely detection and timely response to those outbreaks for someone, mainly because of the lack of quality field investigation. If you don't have a quality field investigation, you cannot detect those outbreaks early. You cannot monitor the timely detection. You cannot also monitor response activities. So the main issue is the quality of data that we have. The main issue is the lack of quality field investigation. And most importantly, the issues related to cluster investigation, contact tracing, and active case search. Okay, next. Again, when it comes to recovery, also we need to conduct a lot of after action reviews in order to know the lessons learned from emergencies, lessons learned from outbreaks, and this is also lacking in most of the countries. Also, we need to assess and monitor the population immunity, okay, and institutionalize also the operational training and learning and strengthening also the workforce continuity. Next. Okay, so models we have to think about, and we need to reassess those traditional disease-specific models and to try to look at the new needs that emerge because of the vulnerability, conflict issues in EMRO. Emerging emergencies also require integrated operational competencies. So we need to identify those integrated operational competencies, and we need to work together in order to make sure that our workforce dealing with emergency and outbreak are having sufficient competencies that enable them to deal with those situations. Need for also multi-hazard emergency preparedness and increasingly important, importance of humanitarian coordination and incident management system. Operational flexibility and adaptive leadership is needed and essential if we would like to have effective response. Transition towards operational public health emergency workforce development is critical, and we need to rethink about that. Next. Okay, so the role of WHO in graded emergency in the stable settings, like we are supporting routine surveillance and immunization support. However, for grade 1 emergency, we are supporting countries to enhance outbreak monitoring and field support. And in grade 2 emergency operation coordination and rapid response support. In grade 3 emergency, we have embedded emergency workforce and search capacity, and we are implementing the 3-level incident management system and operation. Higher grades require stronger search coordination and also operational management capacities and huge resources and involvement of international community. Next. Competencies also needed, like outbreak analytic and also operational epidemiology, risk assessment, vaccination emergency, incident management system, humanitarian coordination and security awareness, risk communication and leadership negotiation and decision support, and data visualization and development of dashboards. Next. Capacity. National capacities alone may not be sufficient during large-scale emergency. Increasing need for rapid deployment of regional search workforce. Cross-border outbreaks require coordinated operational support. And this is also true for the huge population movement that is observed nowadays. Potential for peer-to-peer learning and exchange of experiences between countries, support regional solidarity and health security is also very much needed. Next. Search platform. So we are like looking forward to have a regional search platform, rapid deployment during grade 2 and 3 emergency, cross-border outbreak investigation, rapid risk assessment, and support of vaccination, emergency surveillance, as well as temporary augmentation of the national workforce is needed. Support to incident management again is needed. Next. Those are the consideration, governance and deployment mechanism. We need to agree with national governments. The duty of care and security management is highly needed because of the risk to health workforce. Also, like funding sustainability and search finance, issues related to language and context. So that is why we are insisting to have our regional workforce and integrate search workforce, integration with national system and humanitarian architecture, also avoiding duplication when it comes to response or duplication when it comes to mobilizing resources or when it comes to surge activities and other support provided by other counterparts as well. Next. So, institutionalizing immunization focused FETP with an emergency preparedness framework is critically needed. Expanding competencies beyond surveillance and towards operational outbreak management, strengthening integration with incident management system across all levels of at national level, at regional level, as well as international level, institutionalizing also rapid risk assessment and outbreak analytics, develop standardized competency framework for fragile and conflict vulnerable settings, strengthening regional collaboration and search support is needed, align with immunization agenda, international health regulations, and other regional and international security priorities. I think that is all. No, that is all, I think. Closing remarks, fragile settings require more than epidemiologists. They require operational public health respondent capable of prevention, preparedness, detection, assessment, response, and recovery. The future of immunization-focused FETP may lie in the building agile, deployable, and resilient emergency public health workforce model for EMRO and beyond. Thank you very much. Sorry, took quite long actually.
Thank you, Dr. Tayyib. It's always a pleasure to attend your sessions and hear from you. And actually, you have covered a very broad scope for the FETP, both at the comes to immunization program and also within the emergency response framework. You mentioned also very important, I think it will be the theme for the webinar, which is adaptation or adaptability. And this is actually one of the key themes for this webinar, how FETPs are adapting to the emerging public health priorities and global health. Global health seems like the 717 concepts, and actually it was mentioning that currently Infinite is doing an effort in integrating the 717 concepts into FETP curricula, but this is maybe we have a focus for another webinar with more focus on the themes of emergency response. And you mentioned also some points related to the support for emergency readiness, simulation and testing systems for emergency response, and so on. And now we'll move to the next presentation. We'll introduce our speaker, Dr. Basuri. She is a senior technical officer at Infinite, and she has more than 7 years of experience supporting regional public health workforce development initiative. And she has extensive experience in development and customizing actually FETP trainings and supporting different FETPs across the region. I'm really looking forward to hear from Dr. Ruba today. I've worked with Ruba for 4 years now. 4 years. Yeah, over to Dr. Ruba.
Thank you so much, Dr. Amna. So let me start by sharing my screen first. Okay. Okay, can you see it now?
Yes, if you could put it in the slideshow.
All right, so thank you so much, and good evening. Thank you for organizing and joining this webinar. Actually, I'm glad and honored to be part of this webinar with our distinguished experts. And thank you, Dr. Tayyib, for providing recommendations on how we can scale up the FETP role as service providers on the ground. So during my brief presentation today, I'll start with why immunization itself remains one of the most consequential investment in global health. And I know that Dr. Tayyib covered this maybe better than me. And I'll describe the role of Infinite in supporting FETP in general and the focus on this, let's say, disease-specific or special FETP track. So let me first start where everything begins with why immunization matters in the first place. And it becomes obvious that immunization is one of the most cost-effective public health interventions in the current period or history. So the numbers you can see here tells how significant it is. So you can see some facts from the immunization agenda 2030. And here you can find that this agenda endorsed by the World Health Assembly in November 2020 sets a clear ambition to save 50 million additional lives by 2030 if the strategy, of course, is fully implemented. And that target is unprecedented, and it depends on countries being able to reach the children behind those numbers. And we now have vaccines against more than 20 life-threatening diseases, from measles and polio to HPV, RSV, and rotavirus. And this maybe keeps expanding. And the third thing that every year approximately we have 20 million infants still do not receive a full course of even basic vaccines. And many of them live in fragile, conflict-affected or remote settings. And these are exactly the children that we call the zero dose. So this agenda also names the 3 strategic priorities that matters directly for our work, reaching every child, including in fragile contexts, strengthening the surveillance and outbreak response, and building equity, demand, and trust through risk communication. So these 3 priorities are precisely the operational competencies that the specialized immunization FETP track are built to deliver. So we are part of this world. We understand the need, and we need to utilize FETP to deal with this need. Here are some numbers also specific for the AMR. So 3 numbers maybe anchor the AMR immunization burden. First, that the region has 22 countries with widely diverse epidemiological profiles and shared regional risk, cross-border transmission, refugee flows, and climate vulnerability. And the second thing that we have two countries that has endemic wild polio virus, Afghanistan and Pakistan, and both are in our region. Polio eradication, the most global immunization effort of the past 40 years, will be focused in the EMR, and approximately 100 children have been paralyzed by wild polio virus in these two countries over the past 12 months. In addition, we have some EMR countries report that the DTP3 coverage below 70%. And this is below the WHO target. So we are looking at structural coverage gap concentrated in the most fragile context. So what are the threats? So we have these four threats: measles and diphtheria, fragile context, zero-dose children, and the endemic polio virus. So these are all happening now, and they all share one common requirement to solve. That one of the solutions, let's say, is a trained, specialized workforce. And here, this brings us to the question of the workforce gap. So maybe the problem is not only the vaccines availability, maybe at some context, vaccines exist, cold chains are operational, even in the fragile setting. National immunization programs in every MR country are structured. However, the problem is in the workforce, the frontline staff who must actually detect the zero-dose children, sustain AFP surveillance, investigate suspected cases, and respond to outbreaks. And here, when we say that there is a workforce gap, what are the consequences of this workforce gap? Here, maybe you can find some examples. First, the AFP detection sensitivity. As you know, that WHO standard for polio surveillance is at least 2 non-polio AFP cases per 100,000 children under 15 per year. And when this rate falls below 2, you cannot say that you would detect a polio case if it occurred. The second thing, that zero-dose children become invisible. So identifying them requires micro-planning, default tracking. So the result programs cannot reach children they cannot see. And also one of the consequences that outbreak response delays, and maybe also Dr. Tayyib mentioned about the 717 and the importance of the timely response to prevent the situation from being escalated. Okay, so now moving to INFNET, and why we are focusing on this. I wanted actually here to mention INFNET vision. To have healthy lives and well-being for people in the Eastern Mediterranean region. And the FETP mandate is to build the public health workforce that detects, investigate, and respond to threat where they happen and when they happen. So the FETP exists to put trained epidemiologists in district provinces where the children are, where the AFP cases present, where the campaigns need to run, and so on. So addressing the workforce gap and applying FETP and connecting this with our vision. So we translate this into three main commitments. The first, the reach. So every child in the MR, including in fragile and displaced communities. The quality. So surveillance system that actually detect cases and find zero-dose children. And of course, sustainability, to have a country-owned workforce capacity that outlast donor cycles. So these three commitments are what guide the design of these focused FETP or disease-specific FETP tracks. Okay, so the FETP, which is the competency and service training program that has 3 tiers, the basic one that expands over 3 months, the intermediate 9 to 12 months, and the advanced over 2 years. So this standard training program, and when we call standard, we are talking about the standard competencies. It built the capacity of trainees and core public health competencies. And here we are talking about the descriptive epidemiology, outbreak investigation, surveillance evaluation, statistical analysis, and scientific writing. So every FETP graduate from any of these tiers, you will find that this graduate is equipped with these competencies. However, what distinguished the immunization specific track that it captured the core competencies of FETP. However, it also includes the specific needs of immunization, such as the AFP active case search, the micro-planning defaulter tracking, the supplementary immunization activities or routine immunization campaigns, cold chain, and vaccine logistics. So maybe the immunization-focused tracks for FETP that were implemented in the region were mainly the FEP, the Public Health Empowerment Program, or the basic FETP. And here just a brief highlight about the features of this training program. So it's in-service training program, and this is the most important unique feature of this training. So 25% of this training will be theoretical or classroom, and 75% is field practice. So officers or public health workers stay in their jobs while they train. So they don't leave their district to attend this program. However, they apply what they are learning to their work settings. The second thing that the core epidemiology curriculum stays constant across all FEP tracks, as we mentioned in the previous slide. However, we update the case studies, the field work, the mandate of FETP, the service they are providing, the competencies, all these dynamic components of FETP into customized per country priority. So, for example, we have the FIB SPO, we have the FIB RSV, and I'm coming into this shortly. The third thing is that the beauty of FETP is that it can be delivered through various modalities, whether it's face-to-face or blended. And this feature is essential for fragile contexts. So, and here I'd like to mention our experience maybe in Sudan during the implementation of one of the FETP cohorts, that although the situation was hard and maybe was a barrier to implement this FETP, however, we managed to complete this training through the various modalities, having the theoretical part as online lectures and focusing on the field activities at that time. Last thing, that this program is co-owned and several discussions currently held about the institutionalization, about sustainability of this training program within the Ministry of Health or National Public Health Institutes. So as I mentioned, FETP is not as static or rigid training program. It's dynamic, adaptive workforce system. And what makes this program dynamic is that it responds to emerging needs. So when a new regional priority emerges, so countries, of course, with the support of IMFNet, we design, validate, launch a new FEB modality. And here you can see the timeline. Maybe I went around 10 years back to show you the immunization specific versions of FETP and how it dealt with the country needs over these couple of years. So as you can see here, in 2015, we started the FEB SPO, and over the couple of 4 years, we also updated the FEP-BFE or scale up the FEP-BFE, which is the basic one. We also introduced the WASH and the nutrition. The 2020, we developed the FEP-COVID version. 2022, we also have the FEP-MERS version. 2024, we went into the FEP-PEO. This is the polio eradication. And during the 2025 to 2026, we have the specialized version for FEP respiratory viruses. And this also show you how we always utilize this program to match into the country needs. So here in a quick overview about the program and how it's expanded in the region. So you can see that around 17 countries in the region are implementing FETP with various tiers and various specialized or disease-specific or area-specific models. And what this show us that this program is really needed in the region, and it's even in the globe because it's also implemented in around 98 countries at the global level. So we have, and here I'm talking about the recent maybe years, we have the 3 immunization-focused basic FETP tracks. So you can see here that the FEB-SPO, the surveillance polio officers, that was developed and focused on AFP detection sensitivity in a fragile district, stool sample logistic, hot case investigation, CV, DPV outbreak response. We have the FEB-PEO, which is quite close to the FEB-SPO. It's polio eradication as well. And this program targets the provincial polio and EPI officers and integrate polio surveillance with routine EPI service delivery, micro-planning, defaulter tracking, coverage survey design. Also recently, we have the FEB respiratory viruses, and we have 2 versions of it, one focus on MERS and one on the RSV. And I leave the floor for my colleagues from countries to have specific insights from these specialized FETP tracks. So as you can see here that we always tailor this FETP and target people to with expanding the core competencies to match the needs on ongoing basis. So you can see here that during 2025, we managed to implement the FEB RSV in Lebanon, FEB-PEO in Afghanistan, FEB-SPO in Sudan, and FEB-MERS in Saudi Arabia. Maybe now we are the middle of this year, and the implementation and some of these cohorts were also expanded and implemented in these countries. So in Saudi Arabia, we have second cohort of MERS that graduated recently. For Lebanon, the same case. Afghanistan and Sudan, we have 4 cohorts graduated within the last 2 years from this program. So what is the idea? That the effective capacity building in public health required more than one-size-fits-all approach, and we expanded this 3-month to be more contextualized and aligned with the country priorities. All right, so here also what IMFNET did beyond the immunization tracks. So what FETP graduates also contributed to during the previous year, 2025, and the current year, we have more than 10 FETP specialized cohort planned or completed. We have more than 13,000 children vaccinated in various countries. We have more than 195 RRT members trained, and of course the FETP developed and published various research papers, and this is one of the FETP mandate. Of course, the country highlights, and I took here Sudan, Afghanistan, Bangladesh, and Yemen to show you how FETP, they are not only take the training is a tool by itself, and to help these public health workers at their national or regional or even global level to support this mandate. So here, this is the FEB graduates or FETP graduates who participated in various activities, the AFP surveillance, active AFP case search visit in Somalia, the zero-dose vaccination, community mobilization, and disease surveillance. All right, so last but not least, here just what enabled us to scale up the FETP role as IMFNET, and how we see the things beyond the training itself, that we believe the effort should be continuous, whether for the FETP participants or the graduates. For example, we always believe on building the capacity of master mentor to support the field epidemiologists in their actual work. We have also the case studies as part of the training that are in continuous updating and development. We have the FETP exchange program, which is one of the most efficient and impactful initiatives where FETPs from various countries are visiting the other implementing countries to see how the surveillance, how they respond, so they can share their experience and knowledge. We also increase the exposure of FETP graduates to more scientific resources through infinite electronic library or publications, engaging them with more scientific writing workshops. Also, we focus on the program quality, whether through the accreditation, the definite accreditation or national accreditation. And we provide the various courses and training programs through the International Academy of Public Health, which is the academic arm of to provide these graduates with continuous learning and be all the time updated. Finally, so what infinite main interventions? We support establishing and supporting FETP programs, whether by adding more specialized tracks, whether with having more FETP tiers, more countries to be involved. And we support them in developing the curriculum customization, evaluation, and institutionalization of this training program. And this is also very essential component. We enhance the training experience through various modalities, maximize the training outcomes through mobilization, service provision, support outbreak response, and we support the knowledge exchange and networking through various initiatives. And this webinar is one of these examples. What we aim or continue our effort to do is to continue scaling the FETP by expanding the specialized tracks and to deepen the technical depth of the situation or the surveillance in the countries through embedding digital tools and extend the NITAG capacity for evidence-based decision-making, sustain FETP and anchor these tracks within the national API or MOH workforce strategies, and to keep this dynamic platforms open for sharing experiences between various FETPs in the region and beyond. That's all from my side. Thank you, and over to you.
Thank you, Taruba, for this insightful presentation, and thank you for highlighting Infinite's regional efforts in FETP generally, and particularly in specialized track and mainly for immunization-focused FETP. Now I think we're running behind the time. We have some Q&A questions. We will leave it at the end of the presentations. Now we move to our next presenter. We'll have Dr. Zaina Farah from Lebanon. She will share Lebanon experience in implementing 2 tracks related to immunization topic, mainly the Public Health Informant Program, the SPO, and the FEP, respiratory sensitive virus focused FETP. As introduction for our speaker, Dr. Zaina Farah is an epidemiologist with more than 16 years of experience in public health and communicable disease surveillance. And also, she's currently leading in Lebanon Field Epidemiology Training Program as scientific coordinator. And also over the past almost 15 years, she is serving as coordinator at the Epidemiological Surveillance Program at Lebanon Ministry of Public Health. Dr. Zaina, we are really pleased to have you today. The floor is yours.
Thank you, Dr. Amna. Can you hear me well?
Yes, and we see your slides.
Okay, thank you.
It just you may want to hide your notes.
Okay, I don't think I have any notes. Just
okay.
a minute.
It just if you can expand the screen, because we see the.
Just 1 minute. And now? Can you still
Yes.
see my notes?
No, now we see the full screen. Over to you.
Okay, okay. Thank you, Dr. Amna. Thank you for AMFNet for giving us the opportunity to present Lebanon's experience. I'll be presenting, I'll be delivering this presentation on behalf of Dr. Nada Ghassan, the FETP director in Lebanon. So FETP Lebanon was launched in 2022 with the support of AMFNet GHD. We have so far 82 graduates with 6 complete cohorts. Cohort 1 was focused on COVID-19. Cohort 2 and 3 were FEP-SPO. We had cohort 4 on One Health approach, and cohort 5 and 6 on RSV. And currently we're having cohort 7 on respiratory viruses with 21 fellows. So here you can see the 6 graduated cohorts. We had fellows from, mainly they were surveillance officers from the surveillance unit. We had medical doctors from MOPH public health departments at the ministry. We had MOPH staff from the Ministry of Agriculture, as well as focal points from sentinel surveillance sites from SARI and for the FEP-SPO, we had 2 cohorts with 25 graduates. Fellows were medical doctors in charge of the public health departments at the provincial and district levels at the Ministry of Public Health. So specific, in addition to the, just 1 minute. Okay, so in addition to the general objectives of the field of the FETP, we had for the FEP-SPO 2 main objectives. It was to enhance fellows' skills in surveillance and outbreak investigation of AFP, polio, and other vaccine-preventable diseases, and to improve reporting of AFP and other vaccine-preventable diseases, mainly measles. So we didn't focus only on polio, but we did other activities related to mainly to measles for these 2 cohorts. During the fellowship, fellows were supposed to work on at least 4 weekly surveillance reports on AFP surveillance. They did, each one did at least 3 data quality audit visits to medical centers, and they investigated measles cases. They also prepared an expanded surveillance report on measles surveillance, and they did sensitization sessions on polio and AFP surveillance. So the training included face-to-face workshops, online modules on the AMFNet learning platform, in addition to lectures, and we had guest speakers talking on AFP, polio, and VPD, in addition to case studies on AFP, polio, and measles. As outputs for the 2 FEP-SPO cohorts, we had around 200 prepared weekly surveillance reports, in addition to around 75 data quality audit visits to medical centers. Fellows did 25 sensitization sessions attended by around 308 focal persons in hospitals, primary health centers, schools, NGOs, in addition to GPs and pediatricians. As for the FEP-RSV, we had also 2 cohorts with 29 graduates. Fellows were surveillance officers, in addition to focal points in sentinel surveillance sites, ILI and SARI, and staff from the Ministry of Agriculture. They also worked on weekly surveillance reports on acute respiratory infection surveillance. They did data quality audit visits to primary health centers. They investigated suspected RSV cases, and they did sensitization sessions on communicable disease surveillance for healthcare professionals. As outputs for the FEP-RSV, we had around 200 prepared surveillance reports, around 86 data quality audit visits to SARI, ILI sites and health centers, in addition to around 30 sensitization sessions attended by around 200 focal points at the primary health centers. So what's the impact of FETP on surveillance performance? Field epidemiology training programs help graduates to improve their skills in data collection, analysis, interpretation, and communication. They also help them have more skills in outbreak investigation of communicable diseases, including VPD. Graduates will be more skilled in managing public health emergencies, including those involving communicable disease, and this is part of the FEP curriculum. This is all will lead to improved surveillance performance during emergencies. As for Lebanon's context, so recently we had deterioration in security conditions, and unfortunately we have widespread destruction and infrastructure damage. This causing closure of some hospitals and primary healthcare centers, constraining access to health services. This is also causing a large-scale population displacement and overcrowded and inadequate shelter conditions for IDPs. So this increased the risk of communicable disease transmission related to crowding. So what we did as FETP in this situation, so we had two cohorts during emergencies, cohort 4 and cohort 7. And despite the challenging situation, these two cohorts maintained their activity through customized modalities and deliverables. For example, for cohort 4 in 2024, we added one deliverable is to do visits for the IDP shelters. So fellows did the visits and to assess the risk of communicable disease transmission. And then they did the SWOT analysis for that. They did also sensitization sessions to municipality focal points to improve reporting from the community. Currently, we're having cohort 7 with the current situation. So we're trying to have for the workshops using a hybrid modality. Fellows and mentors who are not able to join face-to-face, they're joining online. And fellows are currently involved in investigating clusters of diseases in shelters. Most of fellows and graduates are actively engaged in emergency surveillance-related activities, aiming at improving reporting from the different sources. They're part of the rapid surveillance teams located at the central and provincial level. They're also involved in field missions and in various training activities. They're also working on the IDP shelter surveillance, which aims to monitor communicable diseases and detect alerts in IDP shelters. This is through online training of focal persons in shelters, field visits, and reporting system from shelter focal points. What are the lessons learned? So from our experience, this highlights the importance of field epidemiology training programs for emergencies, preparedness, and building national capacity. This highlights the flexibility of training programs to adapt to emergency settings. This also highlights the importance of collaboration with FETP networks to facilitate the exchange of expertise and sharing material. And most importantly, this shows the key role of MFNET in supporting field epidemiology training programs in the region. And thank you.
Thank you, Zaina, for this brief yet very comprehensive and insightful presentation for the specialized cohorts implemented in FETP cohorts implemented in Lebanon. And again, the adaptability here is especially the program managed to adapt to the evolving security situation in the country and actually adapting the program deliverables itself to the emerging health system needs, doing risk assessments as a deliverable and actually adapting the whole program to the setting. Now we move to our next country experience. We'll have reflections on the FEP or Public Health Empowerment Program, Immunization-Focused, or other name is a Public Health SPO. Our next speaker is Mr. Ismail Adani. He is a senior public health professional with over 25 years of experience in immunization and primary health care systems in Sudan. He currently serves as the EPI manager for in Federal Ministry of Health. And actually, he led the EPI program in Sudan in a very difficult time of war. He has extensive experience also working in different organizations and UN agencies. Mr. Ismail, the floor is yours.
Thank you very much, Dr. Amna, and it's my pleasure to be here with you now in this webinar. And I think this is a very important presentation from Dr. Taib, translate all the efforts that we can do in our country, especially in this context. So I think you will present from your side, Amina.
Yes, Ammar, please, if you could share the slides.
Okay, thank you very much. Next, please. Yeah, I think regarding the background of our country context, now, as you know, in Sudan, this conflict during last 3 years, starting from April 2023 up to now, I think in some area, this affected our program and I think put country in the setting of fragile country or affected by conflict in many areas. And this also lead to retreat all the vaccine-preventable disease outbreak, and this affected by low coverage of routine immunization and other services. So that means the accumulation of zero dose and under-immunized population will be also occurred during this setting. So I think when we depend on the frontliner of the EPI program at routine and surveillance officer at locality level, that means the first our defenses in this area of locality and service delivery side, and this need to raise their capacity and be more competent to respond to all the emergencies. Next, please. So if we need to answer this question, why FEP, I think, as mentioned by Dr. Taib, the rapid response to the outbreaks or the diseases or the context need a high capability and the competence person to be in the field to be to respond to all these outbreaks. So we need to make this training for our personnel so as to respond immediately for detection of the outbreaks and diseases, and they have to do their best. So we need to build their capacity in this, especially during this fragile setting or our context. Also, as you know, this gap regarding the field epidemiology competence in Sudan, we need to have these hands to support our country and our program to detect earlier all the outbreaks. And I think the FIP trainers, they did that during that 3 years. Also, I think the design of the module based on this in service training also will support our workers in routine work, in routine immunization or surveillance as routine. Also, we focus on the surveillance and outbreak investigation, and I think I see this myself during the last workshop last week. All the participants, they did the investigation of cases, and they also visited the field to know and or to have like some skills for this outbreak investigation and response and improvement the routine immunization program. That means now we are not focusing only on the surveillance system, but also the program and the module touch on the other components of our program, so the skills will be raised at that time. Next. If you go through history, I think our experience with Infinite and this FEP program started more than 9 or 10 years ago. We conducted this program, but at that time, we focus on how we can decentralize the integrated vaccine preventable disease surveillance and how we can cover all the country or all the state by this capacity or training. But recently, during this conflict, I think we focus on plan to cover the locality and state level so as to be ready in response and to be ready to detect the disease earlier and having the responsibility of response. So this is now, I think we succeed to do that. And also, I think one of the issue, the response urgent need, this also we did during our last outbreak, especially in this measles outbreak or measles rubella outbreak, diphtheria outbreak in River Nile and Kassala and Northern State. I think our colleague in the locality level, they did a great job due to this capacity that they have. Next. I think regarding the design, all of us agree on the design that can translate for the locality level, and they can take all the knowledge and skills at that level so they can translate this to a plan and implementation. Also, the adjusted timetable to cover other program components like routine immunization, cold chain, capacity and functionality, and vaccine management issue. And I think this touching in the module. Also, the field visit during workshop. Also, I see this last week, the field visit during the workshop and reflecting the findings from that visit to all participants and sharing the experience together. I think this also add a lot. I think the practical exercise that will make our participant or our people or our staff, they can be capable to deal with the surveillance issues or routine issue. Also, the documentation of the discussion during the workshop and during the training. Also, this make evidence for the upcoming trainings, and we will be benefit from preparing the other workshop documentation for all program steps. Also, it is now in place. Enhancement of community-based surveillance, because as you know, Sudan now implemented in this community-based surveillance, especially when we covered by Infinite or supported by Infinite. I think now we succeed to reach many communities through this community-based surveillance, and we receive some result and feedback from them. Also, the knowledge be sharing between the state and locality level due to their experience from the field. They share their experience. I think this will add a lot. Next. I think this one of the benefit from this FEP and the competencies that we need. We benefit from this module and this tool and this training and this program for the surveillance report and for the data quality. I think also one of the issues that we discussed during our training, the case-based and outbreak investigation. And I think we did this in measles, cholera, and AFP cases, even meningitis and diphtheria. Use of surveillance data for decision making, I think all the time we talk regarding the surveillance means data for action. And I think all the locality level now, they know that they're collecting data so to have this decision regarding the situation and regarding the outbreaks and how they can respond. Also the leadership and micro planning, supervision and other project management. I think this will also be one of the core area that discussing during the workshop. Community-based surveillance now, especially in the hard-to-reach area and displaced population, we conducted well, and we have this communication between the EPI program at all level and the community and receiving the data from their side. Next. I think we have some takeaway. I think we need to, for this FEP to be part of our EPI or the national EPI program and the surveillance system. And now in our steps to do that. And also if we succeed to expand these cohorts to cover the high risk state, I think we will be in good manner if we succeed to do that. And also if we manage to develop like Arabic version for this module, I think also it will be better for all of us because we deal with lower level. We need to be very to know everything about this program in details. So we need to develop like a version in Arabic. Also, if we succeed to strengthen linkage with emergency financing and outbreak response mechanism, I think we will be in good manner. And also, sometimes we need to this mixed modalities of reaching out like hybrid and virtual modalities to be also conducted. Next, please. And this is key message for all of us. As you know, Sudan is starting this program earlier, and now I think we are familiar with the program, and we can add a lot on this according to our experience and the feedback from the field, and also the competency based for the frontliners in locality level and centralized site or a service delivery site. Also, they have some skills and knowledge regarding this and reflecting in practice on that. And also the gap between surveillance and data for action. I think now we are in the good shape how we can bridge this gap between the surveillance and data. And I think all of this issue the FIP can give this to our participant and our staff, and also add to their knowledge and skills to be competent to do their job. Next, please. I think this some photos. Next, show what I presented regarding the workshop itself and the field visit and the feedback and reporting and so on. You can move on these photos, so you can go next for the yes, and also all these participated in this, even the political commitment and leadership, and for the competent people like Prophet Fatih Malik participating in all FIP training. And also here you see the DG and Dr. Haitham from Infinite, also they sharing their reflection regarding our training and so on. And this all these photos can reflect where we are regarding this FEP program. Next is in the field. Next, please. This is like acknowledgements for Federal Minister of Health leadership, and always they supporting EBI program, starting from His Excellency the Minister Dr. Haitham, and Undersecretary and DG of PHC. And I think this supporting from this or this political commitment can help us a lot on that. Even the acknowledgement for Infinite, and I think Infinite also with Dr. Haitham and Dr. Nada Jafar and Amna Khairi. I think they know the context of the country, so they facilitate many issues, and they can translate our effort to the higher level in Infinite. So this also can support the country, also the state level, because they are doing the according to the guidelines and the SOPs and regarding the surveillance and outbreak investigation and so on. And I think we have to acknowledge that even the vaccinators and the focal point of surveillance at the level of frontline. So thank you very much for all of you. Thank you.
Thank you, Mr. Ismail, for this very insightful presentation. And I was really glad to see in the photo some colleagues, old colleagues I have all worked with them during my EI days. Really glad to see them still working on the field. And the country is benefiting from their long experience in EPI and in vaccination. Now we have passed our allocated time for this webinar, but all the presentations were very interesting, and they were touching on very important points regarding vaccine-preventable disease prevention and control, and specifically also they related to FETP and the immunization focus of FETP. We have a few questions at the Q&A, but the time will not allow us to go through all. You can take two questions from the Q&A. I see one question from Dr. Mahendar. He mentioned, I think, Dr. Tayyib, maybe you can answer this. He mentioned, I think immunization should be part of a One Health approach of the issue as emergencies are complex and have issues with overlapping issues, of course, health, nutrition, water, sanitation, and other disciplines. So what do you think regarding this? Dr. Tayyib, if you'd like to take this question.
I think, Dr. Amna, maybe your voice was not very clear, so I'm not sure if he heard you or...
Okay, so we can take two questions from the Q&A. We have one question from Dr. Mahendra, mentioned something about the need for One Health approach in emergencies, as the emergencies are complex and there is overlapping themes. Not just health, we have water and sanitation and other disciplines. So where we are when it comes to this in emergency, and the question is addressed to the WHO approach. So Dr. Tayyib, if you could answer this, maybe you can provide some reflections on this.
I cannot hear you very well. Sorry. Can you repeat?
Can you hear me now?
Okay, can you try? Just
yeah. So maybe if you can see the Q&A section, Dr. Tayyib, and also I ask other speakers if you can go through the Q&A and answer the questions as relevant. Dr. Tayyib, there is two questions maybe relevant. One related to the One Health approach in emergencies, And also another one from a colleague who is working in cross borders. He's also have inquiries about best practices for cross-border coordination
You
when it
know,
comes
I'm not
to
familiar with
emergency
Zoom.
response and
I'm working
VPDs.
with Teams.
So yeah, I will leave it to you, Dr. Tayyib, for the answers at the Q&A. Maybe you can type some answers for these two questions. Because of the time, and now
Okay.
we have allocated time actually for the webinar. One question from Dr. Salman, I think this have been also mentioned through the case studies from the countries regarding the adaptability of deliverables specific to immunization, for example, immunization campaigns, reports, and surveillance performance indicators specifically for AFB and fever and rash surveillance. Dr. Zaina, you have mentioned some examples related to adapting the deliverables related to the program. You mentioned some examples related to AFB surveillance, maybe, or measles. Maybe you can elaborate on that question from Dr. Salma.
Yes, I think from our experience, this what we did. We adapted we changed sometimes the deliverables depending on the situation, but for some, but you need to keep in mind that some deliverables cannot be done at the for the basic level. For like evaluation, we didn't do that because I think it should be part of the intermediate level, right, Dr. Ruba, or beyond? Yeah, but for us, for example, for the sensitization sessions, we started these from the beginning. It was an additional deliverable that was not requested in the curriculum by ANFNet, but because we wanted to improve fellows' communication skills, so we added this deliverable, and for the others, they were added during emergencies depending on the situation.
Okay, thank you, Zaina, for this elaboration. Now I will have, because we are now, the allocated time is officially finished, and we added extra 5 minutes for the webinar. But now, colleagues and the speakers, if you do have final remarks, starting by Dr. Tayyib, 30 seconds for final remarks. Hello, colleagues, can you hear me?
Yes.
Okay, sorry, it seems like a face technical issue. Now, as we are closing the webinar, final remarks from our esteemed speakers, 30 seconds for each max. Dr. Tayyib, if you do have any final remarks, please go ahead.
Okay, don't have any final remarks, but thank you very much for this opportunity. And try to look at the questions and answer. I will respond to questions that are directed to me, inshallah. We have very much interruption here as I am participating in another training. Thank you very much, and this is a great opportunity.
Thank you, Dr.
Discuss a very
Tayyib.
great and important issue, and I hope we can continue our dialogue about this in future, and let us join hands in realizing it. Thank you.
Thank you, Dr. Tayyib, for this really insightful contribution, and we're really glad to have you today. Dr. Ruba, Dr. Zaina, if you do have any final remarks, to Ismail.
Thank you. Thank you for the opportunity. And we hope to keep this collaboration ongoing with AMFNet and with other countries in the network. Thank you.
Thank you all. I would like at the end of this webinar to thank the participants who have joined us today, and also great thanks to our esteemed speakers who have really heard a lot of insightful experiences actually across the region regarding the immunization-focused FETP and generally the specialized tracks for field epidemiology training programs. Key takeaways from this webinar is there is a need for the strategic focus of FETPs from the disease focus to the all-hazard approach, and also focusing the competencies to contribute not only to outbreak response, but also to the operational aspects. And adaptability was the key, adapting to evolving, setting the examples that we have from Lebanon, how it was adapted to the emergency situation, and adaptability also to the global approaches when it comes to, for example, the timeliness and accountability monitoring the 717 approach, and also placing the immunization-focused FETP within the emergency frameworks. And we have heard some excellent examples of how FETP is adaptable in terms of adapting the program deliverables, adapting the themes, adapting even to the level of implementation. We have heard examples for decentralization of the training to district level staff, caring for mid-level management and the state staff. At the end of this webinar, thank you all for being here, and hopefully to be engaged with you in future topics. Thank you.
Thank you. Thank you. Thank you for you, Dr. Amna, as well, for great facilitation.
Thank you.